So I'm going to be talking about focusing drug trials, and really should we be focusing on seizure etiology or epilepsy syndrome. And
it's the green button. Yep,
this
there
one.
you go. Yep, you did.
Okay. Oh, now it's gone twice. So it's the green arrow, right? Okay. So first of all, the objectives: how does or how should classification of epilepsy inform drug treatment? And I'm going to talk a little bit on when we should be thinking about targeting seizure type or epilepsy type versus etiology versus epilepsy syndrome. So here's a wish list for a novel anti-seizure medication. And I think all of us, patients and physicians alike, have the same wants here, and they're not too much. We would like the best seizure control. We would like that with the least side effects, and we would like that as quickly as possible. We would like a therapy that not only helps seizures, but also the non-seizure symptoms of epilepsy, the comorbidities. And we would like that anti-seizure medication to be applicable to as many persons with drug-resistant epilepsy as possible. So this is our Christmas ask. And so why is target important? And so when you look at epilepsies, epilepsies are really a group of quite heterogeneous disorders, many different seizure types, many different etiologies, many different syndromes, and they all have the common end point of leading to recurrent unprovoked seizures. And so if you kind of think about the epilepsies like these colored balls, and if you have a therapy that you think is going to be very, very helpful for the yellow epilepsies, and you're really going to target the yellow epilepsies, but that therapy is also effective for the green epilepsies and the pink epilepsies and the red epilepsies and the blue epilepsies, you might actually help the people with the yellow epilepsies, but you are going to harm potentially the people who have the other epilepsies, right? So if you choose too narrow a focus, you are going to miss the opportunity to use an efficacious, broader spectrum agent for other drug-resistant epilepsies. But we also have the other problem. So if we choose too broad of a focus, so say we're going to now target our therapy for all epilepsies, and we know that that therapy is really helpful for the yellow epilepsies, somewhat helpful for the pink epilepsies, but actually makes the red and the white epilepsies much worse. We are going to risk diluting those results, and we're going to risk not showing efficacy of that therapy, even though that therapy may have a really clear benefit for a subgroup of drug-resistant epilepsy. So we don't want to do that either. So target is really important. We need to know where to focus this. And I think this is something that we're all aware of. This is the 2017 classification of the epilepsies. And I think it really shows very nicely how we think about characterizing. It's a lovely framework for people with epilepsy. So you can see here, the top is really seizure type. What types of seizures does the person have? The next level down is epilepsy type. If you have all focal onset seizures, it's a focal epilepsy. Likewise, all generalized onset seizures, it's a generalized epilepsy. But we have this purple box here, which is combined generalized and focal. And that's really important for many of our young children with the developmental and epileptic encephalopathies that have both generalized and focal onset. And then below that, we have epilepsy syndromes that applies to some, but not all persons with epilepsy. And really at every level, we're thinking, what is the underlying etiology and what are the comorbidities in that patient? So first of all, when should we be targeting seizure type, or how does it help to target seizure type? Well, this has historically been the target of most anti-seizure medication trials, right? The partial onset seizures. And I think this is reasonable if each seizure type has the same pathogenic mechanism, regardless of the underlying etiology or the syndrome. But that's probably not the case. I think sometimes when we're doing this, we're comparing apples and oranges. Now, the pros here is it can include larger patient numbers because almost everyone we can identify a seizure type for them. However, these are quite heterogeneous entities, and they vary quite widely in the chance that we're going to achieve seizure control. And as an example here, we have a 9-year-old who presents with focal epilepsy. And looking at her underlying cause, this can be due to a very, very broad range of different causes, some of which are going to have a very favorable prognosis, some of which are going to have a very more concerning prognosis. So this could be a self-limited focal epilepsy, like self-limited epilepsy with central temporal spikes, which is going to be outgrown. This could be a non-progressive lesion. Could be something like encephalomalacia, which usually is drug responsive, or focal cortical dysplasia, which usually is drug resistant. This could be some type of a progressive lesion like a tumor. She could have an underlying genetic pathogenic variant like DEBDEC5, or this could be a progressive inflammatory condition. So diverse etiologies and pathologies really result in quite varied responses to treatment. Well, let's talk about targeting etiology. And I think here's significant advances, and we heard yesterday the significant advances in genetics, as well imaging and neuroimmunology. And that has really advanced our understanding of the etiologies for the epilepsies. And now we can identify an etiology in probably more than half of patients. So the pros here is that etiology is probably a more accurate predictor of outcome than is seizure type. So again, we know that there are certain etiologies, high rates of drug-resistant epilepsy and comorbidities, things like focal cortical dysplasia, some of the low-grade tumors, certain metabolic disorders, or some of the rare monogenic disorders like CDKL5. And I think it does make sense to target etiology if you have a therapy that actually targets the underlying pathogenesis. And we've heard about some of those therapies yesterday. And I think we're seeing a lot of interest in some of these disease-modifying therapies or precision therapies that do target the underlying pathogenesis. And the hope is that this will lessen epileptogenesis, as well as potentially prevent some of the comorbidities. And while this is still limited, we are all very excited that we're seeing this as increasingly being the focus for some of these rare orphan disorders that lead to really bad epilepsies early in life. So we're seeing therapies that target specific ion channels, genetic replacement or genetic modulation, the antisense oligonucleotides, and substrate replacement. The cons about targeting etiology is we still have about 40 to 50% of people where we don't know what's caused their epilepsy. And so they would be left behind if all we did was target etiology. We don't want to do that. We also know that many of the specific etiologies are very rare. And so that's going to be a limited population that's going to benefit. And we also know that sometimes just the etiology alone is not enough to know how to treat the patient. So a good example here is this young boy who clearly has an ash leaf macule, who has cortical tubers. So we know he has tuberous sclerosis, but unless you know if he's having infantile spasms or what type of seizure he has, you're really not going to know what the best treatment is. Well, how about epilepsy syndromes? So Jackie would know this as well, but we've spent the last 4 years of our life defining epilepsy syndromes, and the papers are just out now in Epilepsia last month. And we've defined an epilepsy syndrome as a characteristic cluster of clinical and EEG features that is often, but not always, supported by specific etiologic findings. Syndromes often are age dependent, but again, not always. And they often have a range of specific comorbidities or conversely lack of comorbidities. And many syndromes carry prognostic and treatment implications. And we do a really good job of identifying syndromes early in life. So before 3 years of age, more than half of kids can be identified as having a syndrome. In childhood, it's about 1/3 of all kids, but this is less common in adults. And we know that their syndromes are generally better predictors, again, of outcome than is seizure or epilepsy type. And we see here in the yellow, the well-behaved syndromes. So these are the self-limited epilepsies or drug-responsive epilepsies, including many of the idiopathic generalized epilepsies. In red, we see the bad-behaving epilepsies. These are the developmental and epileptic encephalopathies, or epilepsies associated with progressive neurological deterioration. These are going to have drug-resistant seizures, and these patients are going to have a lot of other comorbidities. And then we have some syndromes that are sort of intermediate in outcome. And for some of those, I think etiology is very helpful in knowing how they're going to behave. So how about targeting syndromes? Well, the pros here is that syndromes are generally quite distinct clinical entities, often with a specific type or types of seizures. The prognosis is often quite uniform, and these also have associated comorbidities, and so we can measure the impact of our therapies on these comorbidities. The cons is that not all syndromes have a single etiology. So things like Lennox-Gastaut syndrome or infantile spasms are due to a range of different etiologies. We also know that syndromes can have multiple seizure types. And you can run into the case of your therapy helping one seizure type, yet worsening another. And so in this situation, I think targeting specific seizure types within a syndrome may help broaden the reach of drugs. And again, many of these syndromes are relatively rare, particularly in the adult arena. And so benefits are limited to a small group. And as health care providers, we really want to have a therapy that we can give to our patients with drug-resistant epilepsy. And so sometimes that actually leads physicians to overdiagnose a syndrome to try and gain access. And I think we all saw with approval of Epidiolex, there was a little bit of an explosion in Lennox-Gastaut syndrome. So moving on to etiology-specific syndromes. So we know that this is, combining etiology and a clear clinical correlate. And so some of these have distinct phenotypes and they are caused by a very unique etiology. So just some examples that are listed here. So KCNQ2 DEE, CDKL5 DEE, some of the structural causes, metabolic, immune, and infectious causes. And for some of these, if we can identify that phenotypic spectrum clinically, we say, here, let's look for this disorder, let's look for this etiology. And if we find that, that is very, very helpful in knowing how to treat the patient. So let's talk about, when should we target etiology? I think targeting etiology makes sense if you have a proposed therapy that specifically acts on an underlying etiologic mechanism. So that therapy is not just anti-seizure, but that therapy is potentially anti-epileptogenic. In addition to helping seizures, the hope is if we can target that underlying etiology, we can ameliorate comorbidities. And so in that case, we really want to make sure that we're measuring comorbidities in any trial design. And if effective, this is probably a therapy that we don't want to wait, third or fourth line. We want to be using a therapy like this really out of the gate as soon as we make the diagnosis. However, this will likely benefit only a minority of drug-resistant epilepsies, but in that particular subgroup, those effects are likely to be quite profound. When is it reasonable to target syndrome? Well, if the mechanism targets, again, the underlying pathogenesis of the syndrome, if that is known, and we know that for some syndromes like Dravet syndrome, but we don't know that for other syndromes. The other reason it is the other time it is reasonable to target a syndrome is if there is historical data that suggests benefit in a specific syndrome. And that's sort of the fenfluramine story, right? Back in the 80s and 90s, there was kind of a very characteristic phenotype of patient that responded well to fenfluramine. Then it was recognized that almost all of those patients had an SCN1A variant and had Dravet syndrome. And so when the medication was initially studied, it was targeted at Dravet syndrome, even though there was nothing really unique about fenfluramine on why that should specifically work for Dravet. In that case, however, if effective, we need to study that therapy more broadly in other drug-resistant epilepsies, particularly those that have similar seizure types. And then targeting drug-resistant epilepsies more broadly, I think if there's no good reason to target an etiology or syndrome based on the underlying mechanism or based on historical data, we need to be cognizant to trial those therapies more broadly, but we want to be sure that we don't cast the net too broad. And so we want to look specifically at seizure types, etiologies, things like that. So basket trials can be potentially helpful there. And then if we have an etiology-specific syndrome with the specific clinical phenotype due to the unique etiology and a true disease-modifying therapy that is anti-epileptogenic and can prevent or reduce comorbidities, that is something we really want to jump on right away because I think time is brain there. If we wait and we treat somebody, for example, with Dravet syndrome when they're 25, we're going to have a very different outcome than if we could jump on them and treat them when they're a year old. So thank you very much and happy to take any questions.